Good afternoon, everyone, and for those of you for whom this is the first session, a big warm welcome to the Isle of Wight Literary Festival. My name is Susannah Dinnage. I'm a media consultant, but today have the absolute pleasure of having an hour of our time with Dr. Suzanne O'Sullivan, the author of The Age of Diagnosis, Sickness, Health, and Why Medicine Has Gone Too Far, a book that asks whether a diagnosis can do us more harm than good. Suzanne has been a doctor for over 35 years and works full-time as a neurologist in a clinical practice and is an award-winning author specialising in neurological and mystery illnesses. Her latest book, which I highly recommend, I've read it, it should be required reading, The Age of Diagnosis, which we're going to discuss today, was a BBC4 Radio 4 Book of the Week and is a revelatory journey of modern illness that overturns long-held assumptions about medical progress. Welcome, Suzanne.
Thank you for coming.
I want to start with a few basics here, because this is going to be a big, maybe sometimes slightly uncomfortable and controversial conversation. What do you mean by overdiagnosis, first of all?
Yeah, so I think it's a super important point, is what is and what is not overdiagnosis. So I think sometimes, especially in the hands of newspapers and in sort of casual conversation, overdiagnosis can be sort of conflated with misdiagnosis, meaning a diagnosis is wrong, or can be mistaken to mean a person isn't suffering. That's not what overdiagnosis is. What overdiagnosis is it recognizes the point at which medicalizing a problem might cause more harm than good. So if I kind of give you I start the book with a story of a patient of mine called Stephanie that I hope will give you some sense of what I mean. So Stephanie's a lady who I looked after with epilepsy for many, many years, and I could never find out why she had epilepsy, but was treating her blindly anyway, failing to make her better. About, I think it was like 10, 15 years into her journey, we realized that she was having difficulty walking. I then failed to explain why that was happening. Tests, everything was normal, and then her husband made a chance remark. He said, Stephanie walks exactly like Abigail. Now, Abigail was Stephanie's 15-year-old daughter, who I understood to be perfectly healthy. But this kind of revelation that both Stephanie and Abigail had an unusual walk and that they walked like each other immediately opened up a line of inquiry that I hadn't had before, and it suggested that this was a genetic condition. And what I did next, I regretted for many years after, which was I arranged for both Stephanie and Abigail to go to a neurogenetics neuromuscular clinic. After many, many investigations, it was revealed that they both had a very rare genetic disorder that manifests as progressive gait difficulties, walking difficulties, and sometimes epilepsy. Now, I had done exactly what I'm trained to do. I could potentially, at the end of this, say, you know, fantastic job, well done. I found the rare diagnosis. I got Abigail a diagnosis before, you know, Stephanie had 20 years of tests, not having a clue what was wrong with her. I'd saved Abigail that. I had found the rare diagnosis. You know, I'd done exactly what I'm trained to do. But I really felt guilty because, you know, I had potentially done exactly what I shouldn't do with Abigail. I turned her into a patient 10, 15 years before it was necessary. You know, she was a 15-year-old woman who had some difficulty running, so she did yoga and swimming instead. The kids in school teased her a bit for her walk. She was resilient, she didn't mind. She wasn't aware that she had any sort of medical problem until I essentially diagnosed her and told her it was a problem. And that could have gone terribly wrong. It could have changed her relationship with her body. It could have changed how she thought about herself. It could have changed her ambitions for her future. It could have changed how other people saw her and treated her. And that's really the very definition of overdiagnosis. It's yes, she did have something wrong with her. And yes, she would have needed a diagnosis eventually. But did she need to have her life medicalized at the age of 15? That's one type of overdiagnosis where you give a diagnosis before it's necessary. When someone doesn't believe they have a medical problem, you're not going to change their future, but you could change it for the worse. And the other type of overdiagnosis is one where one medicalizes ordinary struggles of life with the intention of helping people, but sometimes when you medicalize people, you reinforce their symptoms instead of helping them.
Thank you. I think that's really helpful. And I think one of the other points you make very strongly in the book is that those at the severe or moderately severe end of any disorder, without question, benefits from a diagnosis. So you're not arguing that nobody benefits from a diagnosis, but there's a spectrum and there's a timing and an appropriateness of diagnosis.
100%. So if you think of, let's take any random example, if you think of someone who's got sky-high blood pressure, they're at risk of heart disease, they're at risk of a stroke, they're at risk of a number of different diseases. Medicalizing them is essential so that they can get the correct treatment, so they can prevent, they are threatened by the medical problem that they have, by how high their blood pressure is. And if they don't get that treatment, they're in risk of multiple different kinds of serious diseases. Turning them into a patient per se is not going to make much difference to them, because they have a significant medical problem that requires to be treated, and that's the thing that is potentially disabling to them. If you take someone at the very other end of that spectrum, so severe disease, moderately severe disease, it reveals itself and it is the problem. And if you didn't label it, it would still disable that person and cause problems for that person. So severe and moderate disease is disabling in itself. But if you come to a very mild end of the spectrum, that's where you get this sort of less clear balancing act between the benefits of the diagnosis and the harms of the diagnosis. So if you now come to someone who's got borderline hypertension, the chances are that they won't have a stroke or won't have to go on to develop heart disease. So you have to ask yourself, okay, the benefits of treatment is it does reduce the risk of something that they're not at a terribly high risk of to begin with. And you're balancing that against the harm of the changing, of putting them on treatment that could have side effects, of changing how they think about their health, developing health anxiety, of practical things like now their health insurance goes up, their travel insurance goes up, things like that. So at the severe end of the spectrum, your medical problems are the disabling thing. At the mild end of the spectrum, you've got this kind of delicate balance between what you get from being diagnosed and what you lose from being diagnosed. So when we're talking here today and we hit on different diagnoses, I think it's useful to remember that when I'm talking about overdiagnosis and the harms that come with it, I'm really talking about at this mild end of the spectrum where the symptoms are minimal. That's where the harm exists.
One of the things that I took out of the book, being not a medical person at all, as a base point is something called the DSM.
Yeah.
Because I think probably everybody in the room might have a child, a grandchild or whatever, who has some kind of diagnosis, or diagnosis creep, if you like. And we talk about spectrums. And can you tell us what the DSM is? Because that's really the base point from which all of the diagnoses spread, isn't it?
Well, all mental health diagnosis. So let's start with this concept of diagnosis creep first. We'll start with the DSM. So DSM is Diagnostic and Statistical Manual of Mental Health and Neurodevelopmental Disorders. So it's essentially an encyclopedia of mental health problems. And it describes what the typical features are, what the typical exam findings would be, what the typical trajectory is, or what... So it's essentially defining. If you think about mental health disorders, they're not defined by what you find on a scan or any genetic findings for the most part. They are essentially a constellation of symptoms. And what the DSM does is it defines what you have to look like to have depression, what you have to look like to have severe depression, what you have to look like to have autism, what you have to have ADHD, obsessive compulsive disorder. What's super important about the DSM for people to understand is that it's a cultural document. It's not, yes, it's founded in science to a certain degree, but what it essentially is a book that says this is what we're willing to accept as normal at a point in time. I always give the example, and everyone does really, of homosexuality. It used to be in the DSM because once upon a time people considered homosexuality to be a mental health disorder, and then basically, obviously, it was understood that it was inappropriate to refer to it as a mental health disorder, so it was removed from the DSM. But these kind of decisions are based on how culture and society are changing, and every few years there's a new edition of the DSM, and every new edition of DSM slightly tweaks what a medical disorder will look like. And we may come to it in more detail later, but let me give you the example of that for something like autism. So autism in the DSM many years ago would have been sort of essentially described as an extreme autistic aloneness. It was a disorder that affected people who had learning disabilities. They were people whose social communications were such that they were unable to communicate at all for the most part, and they had no interest in people at all. And then at some point, a group of scientists said, well, maybe these characteristics exist in milder forms in people without learning disabilities. So then the DSM changes to include that idea and says, okay, let's change the description of autism in the DSM and say now you don't have to have a learning disability, and perhaps it doesn't have to be apparent, when you're very small, before the age of 30 months, maybe it's before the age of 3 years, and it tweaks the description to make it more inclusive for more people. And then a few years later, someone will say, well, maybe it isn't apparent, for some people, this disorder doesn't become apparent until you're even older, and maybe the signs are even subtler. And then the new committee that comes together to describe the next version of the DSM will tweak the description again. So now the diagnosis can be made in people who are even older with slightly atypical symptoms. So what I'm describing here is this, what we call diagnosis creep, which is basically where, in order to identify more and more cases of different medical disorders in milder versions and more atypical versions, scientists and doctors gradually tweak diagnostic criteria to make them more and more inclusive. And that's not really a scientific process per se. That's more a process of a cultural decision about how much abnormality are we willing to accept in our children at a point in time. And 60 years ago you had to be severely disabled to be referred to as autistic, and then society changed and the DSM changed with it so that you can have autism with considerably less disability. So that's sort of how the DSM sort of changes for everything. Grief has recently entered the DSM as a mental health disorder, and all of these changes are done for super good intentions, because the assumption is if you can help these people in the severe bracket with medical treatment, maybe you can help these people in the milder bracket even more. But as I've already kind of alluded to, in the severe bracket, you desperately need the treatment because you are disabled by your disorder. But in the milder bracket, yes, you may well be helped by your treatment, but you may be harmed by the concept of being turned into a patient. And I should add, when we talk about diagnosis creep, I'm mentioning here neurodevelopmental disorders. This applies all over medicine. Blood pressure, what used to be high blood pressure when I was a medical student, is completely different to what high blood pressure is now. So they gradually have reduced the kind of limit of blood pressure so that you qualify as having high blood pressure now at a much, much lower level than would have 30 years ago. Similarly, osteoporosis, kidney failure, weight, diabetes. This diagnostic creep is a trend in every field of medicine, where we just keep saying, maybe we can help more people if we just make the diagnostic criteria more inclusive. And then we definitely will help more people, but we also potentially will harm more people when we do that.
And why do you think it harms people? So when some people, I think, again, you talk about in the book, it's wonderful to turn up and someone to say, there actually, is something about you. I can describe it and I can give it a name, and people can feel relief, they can feel listened to, and maybe get some support. Why is that not always a good thing?
Yeah, so I always want to say I don't want anyone to feel that if a diagnosis has been genuinely helpful to them or a member of their family, that they should need to sort of give up that diagnosis. But what I really do want people is, going forward in the future, understanding how a diagnosis can harm people. So again, let's think about that mild end of the spectrum, and you have a teenager in school who has actually done pretty well until they found themselves challenged by secondary school or either socially or the exam changes and how things change when you get into secondary school. It's not unusual now for those sort of difficulties in those kind of teen years to be conceptualized as mental health or neurodevelopmental problems. Now, the difficulty at that mild end of the spectrum is that when you label something as being due to a neurochemical brain abnormality, a neurodevelopmental brain disorder, because if you think about many of the labels that people are given, they're often conceptualized as a serotonin. It may not be medically accurate, but a serotonin abnormality or a developmental brain abnormality or a genetically driven neurodevelopmental brain problem. And we give these labels to teenagers to explain difficulties. What you are potentially doing is making the difficulties they have then concrete. So you're saying, this is not your strength, because there is something in your brain that means you cannot do it. Now, the thing is that people, teenagers particularly, but all people, we all go through troughs and highs and lows, and teenage brains aren't nearly developed. Your brain doesn't fully mature until you're in your mid-20s. What you do when you conceptualize problems as medical is that you potentially make it seem like that is something that is so outside of your control. Now, that gives people relief, because they kind of think, okay, this is not my fault. And I don't want to take that feeling of relief away from people, but I want people to understand that along with the feeling of relief is the potential that it makes that problem insurmountable. I can change. It gets in the way of an examination of life and life's choices if you believe that the difficulty you have is rooted in some brain abnormality. It can really affect a child's self-concept, their belief in themselves going forward. It can affect how others treat them. So the teacher might say, well, that's the child who's got this diagnosis. They're not going to be able to do this. So it affects how one's belief in oneself and others' belief in you. It has the potential really to become a self-fulfilling prophecy. What happens when you're given a medical problem, we've all experienced this, is if you get a symptom which you believe is, I think most people must have had the experience, if we just say you have a headache and it won't go away, and you think you have a brain tumor or something. Now, we won't all have thought we had a brain tumor, but we all thought we have a lump here or a thing here that was serious. And what happens is, when you get that conviction, is that it really focuses you on your body and it exacerbates those symptoms. And once a difficulty, something you can't do, or a symptom becomes the focus of your anxious attention, it really amplifies that. And once it's been amplified, then you pay even more attention. So you imagine an adolescent child who is having some social problems in school or is struggling a bit in school, and you conceptualize it as medical. That can turn all their anxious attention on their difficulties. That will make the difficulty worse. When the difficulty gets worse, that will be a further kind of amplifying effect. So this is the problem with diagnosed at the mild end of the spectrum. You may have a small difficulty that becomes overshadowed by this. We call it the labeling effect or the nocebo effect. If you believe that you're going to get something will make you sick, it can make you sick. So I'm not here suggesting. I went to school in the 70s and 80s, and to the best of my knowledge, in a class of 120 pupils, nobody was recognized as having any special learning needs. I'm not sitting here advocating, let's go back to the good old days of ignoring people. I'm here advocating for recognizing that perhaps a child has slightly different learning needs, and that we can recognize that and give them the support that they need without referring to them using these medical labels. It's the labeling and the conceptualizing things as brain abnormalities that really concerns me, because that removes agency from the person who's been labelled.
I think it's really interesting, obviously, living in a digital age and an age of perfection, and everybody being able to get Dr. Google or wanting an answer now and wanting everything to be perfect. We are, as you described, in a folie à deux with the medical profession, saying, well, we know all this, and I've read this, and and I think this, and so on. And so we'll come to the role of society in all of this as well. But I think I want to touch on science. You know, one of the things you talk about in the book is that diagnosis, this book is all about diagnosis, it is a science and an art. Now, I don't know how many of you get in your Facebook feeds, oh, would you like to spend £2,500 coming and have a full MRI and we'll tell you all the things you haven't got and we might find something and we can offer you a quick treatment on that. We can all go direct to science now. And in some ways we're cutting out the art. Can you talk about the importance of the art of diagnosis? Because this is critical.
It's just super, super important. I mean, I think people we have a sense that, or rather I feel that people have a sense that, when they go to the doctor and describe the symptom, that the scan gives the diagnosis. No. The doctor or the nurse or the pharmacist or the medical professional gives the diagnosis, and the tests are there to supplement. And the tests are utterly meaningless without this really good quality story and relationship between the medical professional and the person and the patient. What I mean by that is, like, a lot of neurologists, myself included, would not have a brain scan unless they absolutely knew exactly why they needed it and exactly what question that scan was supposed to answer. And the reason we wouldn't have a brain scan is because we know that a huge proportion of people have little cysts, little white spots, little abnormalities of blood vessels that you're walking around quite happily with, and you do a scan and you find it, and it may not explain your symptoms, but how do you forget about it once that you know it's there? And these I remind people that, we did not know what the inside of the healthy body looked like until, about the 1990s when MRIs came in. So let's say pre-1990, the only types of scans we had were X-rays, CTs, which big dose of radiation. So you didn't do a CT scan casually because you couldn't be exposing people to regular radiation. So most of the time people had tests because they were sick. But now we have these safer types of tests, blood tests and genetic tests and MRI scans that we can do on perfectly healthy people. But guess what? Because we've never done it before, we don't actually know how many of the perfectly healthy population who live well into their 80s are walking around with all sorts of weird cysts and blood vessel abnormalities and abnormal cells. We're only beginning to get a handle on how our bodies age on the inside, I suppose would be a way to put it. I always say to the students, look at how different we are on the outside. We all have eyes and ears and noses, etc. But, no two of us look the same. And yet, we're looking at brain scans and other types of scans and blood tests, and we're seeing little differences, and we're kind of expecting uniformity on the inside when there's no uniformity on the outside. And we also don't often deal very well with the concept of aging. We age on the outside. I mean, do we think we don't age on the inside at exactly the same rate? So when we start doing scans on older and older people, we're picking up more of these little, what we call incidental omas, just incidental findings that aren't important to your health. So the only thing that matters when you have a scan or a blood test of any sort is, what does it mean in relation to the story that your doctor has taken from you? And if your doctor is able to, or it doesn't have to be a doctor, a nurse, whoever, is able to listen to your story and understand your symptoms, then they can look at the scan and say, well, I think that's incidental and nothing to do with your symptoms. And I think that is important and it is to do with your symptoms. The crucial step in that is not the scan, it's the relationship between the doctor and the patient and their ability to hear and interpret the story. Clinical diagnosis is clinical. Every test that you have has about 100 caveats attached to it. This will be normal unless you're, do you live at high altitude? Are you overweight? Are you underweight? Are you this? Are you that? And doctors have to know all these caveats and don't always know them. So the more tests that you have, the harder they are to interpret. So the good doctor, I think sometimes people don't know what a good doctor looks like. The good doctor is the one who doesn't do the test every single time you go and see them. I sometimes think, if you go and see a doctor and you say you're worried about something and they say, yeah, I'll do the scan, and they're the doctor who does the scan every time, my suggestion would be they're probably the less good doctor, and the one who's good is the one who says, sometimes you need the test and sometimes you don't.
sticking with science a moment, obviously we can now map the human genome, and you know, genetics is a really big question again. I'm just going to touch on the chapter headings, actually, for those who haven't seen the book. There are great case studies for Huntington's disease, Lyme disease, long COVID, autism, the cancer gene, ADHD, depression and neurodiversity, and the syndrome without a name in this book. So it's very broad, and we won't cover them all today. But I want to touch on Huntington's disease, very recently in the news, and also the cancer gene, because in both these cases, you can have a test that will empirically say you have this. So Huntington's, you know, you have this gene. Cancer, you have this gene. But actually, the implications in both cases are slightly different, aren't they? Can you talk to us about how sometimes actually even genetic testing is not always
I think
great?
I even fell foul of this myself a little. Like, I do tests like brain scans all the time, and as I've already said to you, you know, I wouldn't do a scan unless my scan is when I request a scan, I request it to answer a specific question for a specific patient, so that when the scan result comes back, I know what I can dismiss as nothing to worry about and what's important. And yet even I my patients often have genetic tests as well, again, to answer specific questions. But even I kind of fell slightly into the trap of not understanding how uninterpretable a genetic test is without the clinical story, because it kind of comes back with this kind of, you know, this really fancy formula of lists of letters. It looks like super scientific. And I think I somehow also allowed that to kind of lead me down the garden path of thinking, oh, that's a super high-tech, very recent, super up-to-date test that produces a very scientific-looking answer. Those answers must be pretty definite. But actually, you know, all medicine is the same. You know, test results mean nothing without the story. The story is everything. So we've got two different scenarios that Susannah has mentioned here. One is Huntington's disease. So Huntington's disease, the very first disease gene to be recognized in 1993 was the gene for Huntington's disease. And I think it tells a really important story. I really hope that nobody in this room will ever be affected by this story. It's not a very common disorder. It causes awful neurodegenerative decline, where it starts with psychiatric symptoms and then it evolves into people getting funny involuntary movements. And as it progresses, you end up unable to eat, unable to speak, unable to walk, unable to feed yourself. So it's a very unpleasant disease to have and to witness in a loved one. It's a genetic disorder where if your parent has the gene, then you have a 50-50 chance of inheriting that gene from your parent. Therefore, you may see your parent go through this awful neurodegenerative decline and knowing that you've a 50-50 chance of being affected. The gene, before we've known about the disease gene for Huntington's, it was identified in 1993. And before genetic testing became so sophisticated, the Huntington's disease community all very much wanted a genetic test to become available, so that if they were in this situation of a parent being affected, that they would have the opportunity to have the test and find out if they were affected at an early stage, so they could anticipate their medical future. A genetic test is now available for Huntington's, so anyone who has the gene can have the test to find out if they're 50% yes or 50% no. Only in this country, only about 10% of those potentially at risk of Huntington's with a parent with Huntington's has the test. So it's really counterintuitive to me when I heard this, because I think a lot of us would think, you know, if I knew that I was at risk of this, I'd want to know as early as possible that I was going to develop this disorder, because it would affect how I lived my life. It would affect my choices for the future. It would affect whether I had children or not myself. And I met this incredible woman writing this book called, I call her in the book Valentina. And she was in her 20s and she was pregnant with her first child when she found out her mother had Huntington's. And the minute her mother got that diagnosis, she had a 50-50 chance of being affected, and her unborn child went from being absolutely perfect, her first child, to being a child who had a 25% chance of having Huntington's. And her immediate impulse and her siblings' impulse was to test. she saw a genetic counselor who's not a counselor, they're a genetic specialist who counsels people on the risk of getting a genetic disorder. And she realized through her interaction with that counselor that she didn't want to test. That, the minute she tested, were it positive, it would ruin all of her kind of dreams for this experience of having her first child and what it would be like to raise her child. It would affect how she went about having further children. And the genetic counselor helped her to realize that a life full of hope is, if you don't test, you can hope it's negative. And that hope is the most important thing. A life in which you can have any sort of future is often the life that is most worth living. But if she tested at the age of 20-something and discovered she had the gene, she would firstly potentially live the next 20, 30 years of her life just waiting for the first symptom to come on. And the types of symptoms that happen are, you become more anger prone or irritable, or things that we all do anyway, particularly as we get older, perhaps. And, so if she were diagnosed at 20-something, every single thing that happened to her in the coming 20 years would be entirely colored by knowing that this medical disorder was impending. And she could potentially have become someone disabled by the symptoms of Huntington's even before the disease started. And worse still, she would have had to watch her child, who could not be tested until they were 18, wondering what was going to happen to them. It would have affected her ability to have children. So what the Huntington's disease community has realized through their experience of really thinking deeply about this problem is that hope is a really important thing. Living with hope is important. And that's the reason that the vast majority of them in this country do not have a test, even though the test is available. Obviously, as soon as a treatment becomes available, they will test. And as some of you may have seen in the news recently, that a gene therapy has gone through phase 1 and 2 trials that we are hoping is going to be the cure for people with Huntington's. But we're not there yet. So the point of this story is very much, most of you will never be in this scenario, but you can often turn on the radio and hear someone say, well, now you can have a test for Alzheimer's that will tell you're going to get Alzheimer's 10 years before the actual symptoms begin. And I would say to you, why do you want to know that? You know what? Your memory starts declining in your 30s. It's very important for science to know that, because science needs to develop treatments, and treatments need to be developed on people who are pre-symptomatic or in the very early symptomatic stage. But do I want to know that for myself, so that the next time you ask me the name of the book I was reading last week and I can't remember it, I can't remember the names of my own books sometimes, do I need to think that that is my Alzheimer's starting? And I'm not saying any of this to discourage people from having these tests. I'm saying this to, it may be that people feel, I'd like to know that because I've got kids, I've got a mortgage, there are things in my life I'd like to sort out. I'd like a bit of advanced knowledge. I say this not to discourage people from having the test, but to understand that all those little bodily things and all those little brain-mind things that go wrong all the time, especially as we age, can just be blown up if you think you have a serious disease in your future.
It's so interesting, isn't it? Medicalising normal is a really big thing. Yeah. And we do that to ourselves, is what you're saying, of course, once we think there's a problem. Again, I'm looking out at the sort of average age here, for which I'm typical. Has it made a difference now? We've got this generation who seem to have a lot more diagnoses than we did.
Yeah.
Is it making a difference? Is it making their world better for them? Yeah. Are we likely to see a healthy, happy generation when they're our age? Yeah. What's the sort of long-term implications of more diagnosis at a younger age?
I mean, this is
neurologically, of course.
It's enormously the reason I wrote this book. So I qualified as a doctor in 1991. I've been a consultant neurologist since 2004, and I have, many of my patients are young. They're in their 20s, maybe some in their 30s. So I see quite a young group of patients. And I really noticed over the last 10, 20 years that people are coming to me with long lists of medical diagnoses. I mean, most people are very unlucky to have a medical diagnosis at the age of 20 in the past, whereas now we've got people with a big long list of diagnoses. Now, I have no difficulty at all with labels and diagnosis if it is doing what it is supposed to do. So what is a diagnosis supposed to do? Well, it's supposed to identify a cause for your difficulties, but it's also, that shouldn't be enough. It should also sort of hopefully lead to a treatment or cure, but obviously that isn't possible for everything, but at least help you on a path to alleviate your difficulties and improve the quality of your life. And what I'm seeing amongst the cohort of patients that I see is that they're just accruing labels, but nothing is actually getting better in their lives. And that's what always worries me about these labels. If we sort of come back to the concept of autism again, you know, that diagnosis has been escalating in numbers since the 90s probably. And these escalations are all for really good reasons. So they're based on a desire to help more people, and based on the assumption that if you find disorders in milder and milder forms, that it won't do any harm, but it will help more people. We've had escalating diagnosis of ADHD and autism since the 90s. Now, the idea there is good. You know, as I've said, in my school years, I'm pretty sure people who needed help were missed. And the idea is you're finding those people, so we're not missing them. Now, even allowing for the fact that maybe our interventions aren't great, what one would, or aren't optimum, one would hope that if we've had escalating numbers of children in schools being diagnosed with different disorders in their teen years, that we would be seeing some kind of positive knock-on effect. Because the point was, we're taking struggling people, we're recognizing them, we're giving them whatever help we have, and that will make them happier, more functioning adults. Well, we have mental health disorders arising in the 16 to 24-year-old age group more than any other group. We are not finding more teenagers with mental health and neurodevelopmental disorders, helping them and producing happier young adults. We actually have much less happy and much less productive young adults than we've ever had. So irrespective of whether a person agrees that these disorders are being overdiagnosed in adolescence, I think one has to sit back and say, if we're doing the same thing and we're doing more and more of it, and we've been doing it for 30 years, and we're not seeing the positive effect yet, something is going very wrong. I think what sometimes happens in medicine, though, is instead we say, oh, let's just do a bit more of it. You know, it's not working, but maybe that's because we haven't found enough of people yet. I saw there was a thing in The Guardian, I think it was about a month ago, that said that, you know, 1 in 100 people young people have ADHD, say, and but 1 in 100 70-year-olds do not have ADHD. Oh, the conclusion from that was we mustn't be diagnosing it enough in older people. So now we should seek out the diagnosis in older people. And I think sometimes the thought processes here aren't great. I think, you know, if I invented a new medication today for something and I wanted to introduce it to society, it would have to go through rigorous trials, you know, various kind of double-blind, phased trials, and we'd have to really test that the group of people who were getting the tablet were better off at the end. But if you introduce something like a kind of expanded diagnostic concept where you're diagnosing, you adjust a diagnostic concept to find more sufferers, the end point is often how many extra sufferers you find, rather than what happened to all those extra people that you found. And it's the same with tests like scans and genetic tests. You know, we find that something like an MRI scan has absolutely revolutionized medicine. So, and genetic tests are already revolutionizing medicine and will have the phenomenal impact in the future. But what we often do when we develop a test like that is we find a group of people for whom it really makes a difference. So there was a 100,000 genome project. We genetically tested 100,000 people with rare disorders, brain disorders, cancers, who had a family history of these disorders, and found causes for these disorders. I think it was 18% of people got a diagnosis from that, and that's absolutely amazing, which it didn't necessarily cure these people, but it gave them answers they hadn't had before. And then the next step in thought process like that is often, oh, that was amazing, look at all the things we found. Let's do that again, but now let's do it on babies. Let's do it on people without a family history. We just take something exciting and transformative in medicine, and then we just keep doing more and more and more of it, but we're often very slow to do the much more important step, which is to say, okay, what happened to that new group of test subjects?
And I think, again, what's really interesting, I'll be coming to questions in a few minutes, so please get ready. What's interesting for me, again, there's lots of wonderful case studies in the book that really help explain all the points you're making. You talk about how specialists are encouraged to stay in their lane. So as somebody goes, oh, there's something a bit wrong with me, they go and see one specialist who says, I think it's this, doesn't quite answer it. Then they go to another specialist who says, I think it's that. And they get a cumulative collection of labels. So you'll find someone has, for example, ADHD, and they'll have maybe mild autism, and maybe they'll have an eating disorder, and.
Yeah.
And there's sometimes a reluctance for that person, because it becomes who they are, to relinquish all the rest of those labels for the one correct diagnosis for the person who really understands. And I think I can suddenly see why people walk around with a collection of conditions that they find quite crippling and very self-defining.
Yeah, that raises a couple of points. One is about how specialized medicine is now, which is absolutely fantastic, because in one way, so, if I had diabetes, I want to see a diabetes specialist. If I have epilepsy, I want to see an epilepsy specialist, because medicine is so broad, a doctor cannot know everything about everything. So it's nice to have a specialist doctor who you feel can have a really good knowledge of your specific problem. And that's absolutely fantastic. But what I feel has sort of happened now is that we've really lost that sort of person who oversees everything. Obviously, we still have our GPs, and that works better or worse in some places. In London, where I live, you don't have a named GP. You never see the same person twice. I think in smaller places, you still have the benefit of someone who can follow you through life. But the difficulty with this kind of hyper-specialized medicine is that if I see a patient, and I feel I've diagnosed them, I see a lot of people with psychosomatic conditions, so severe physical disabilities that have a psychological cause. And often people who have that sort of problem will have multiple different symptoms that can all be explained by this psychosomatic mechanism. But I don't feel that I can address the diagnosis of, I've written a story of a young woman in the book called Darcy, and she's very typical of patients that I see. She's only, I've forgotten how old she is now, but let's say in her 20s, early 20s, and she got one diagnosis after fainting, and then she got another diagnosis that led on from that. So she came to me with about 9 different diagnoses, and she came to me with seizures. So she'd started out just fainting, just collapsing to the ground like a faint-like episode, and that had kind of escalated over time into fainting and then having a convulsion, which is actually surprisingly commonly caused by a psychosomatic disorder, just a purely psychological mechanism. I was able to test her and show that her seizures were purely psychological in origin, but then I kind of go back to the very beginning of her story and try and establish sort of how the trajectory of her illnesses took place, and it really was like, she got one diagnosis, and then because certain diagnoses are associated with other diagnoses, then she started getting other labels. So, if you have this, could you have this also? Because these often go together, and then she'd get another label. And until in her 20s, she had about 9 labels. And I really wanted to kind of go back to the very beginning and challenge, what are the chances, I will say to patients, that you at the age of 20 have 9 different things wrong with you? Does that make complete sense? Some people are unlucky, but few people are that unlucky. Is it possible that we can come up with a unifying mechanism that explains all your symptoms, or even the lion's share of your symptoms? But unfortunately, in that situation, someone like Darcy will say to me, well, Dr. A gave me that diagnosis, Dr. B gave me that diagnosis, and I don't want you to challenge my various diagnoses that were made by other people. And because we're so specialized now, it is actually quite difficult for one doctor to say to another, I'm not sure that was right, or and it's also quite difficult for doctors to have. I think a lot of doctors just get into the habit of just staying in their own little niche, so that you end up ignoring the bigger picture. And I'd love to go back to a time where we had more. I don't want to abolish specialists because it's so useful, but where we also have generalists who can notice when someone's getting multiple labels for the same thing and can draw it all together and knows the person as a person, and also someone who can look. In another pattern that happens is you get a medication that gives you get a painkiller, it gives you heartburn, so you get a tablet to deal with the heartburn from the painkiller, and then you get a tablet to deal with you got tablets to treat the side effects of the tablet that treats the side effect. I think we're going to go on to questions, but I quickly wanted to touch on the other thing you said, is also with people like Darcy, what I found challenging is illness as identity is becoming a bit of an issue now, is that the people get great relief from a diagnosis. They identify with it and it becomes very integral to their identity. But if a medical diagnosis is very integral to your identity, how do you recover? If a medical diagnosis is integral to your relationships and your support groups, if your life revolves around your medical diagnosis, then that's going to reinforce your symptoms and give you very little chance of moving on. And I think that's a big problem we have in society now.
And there's a brilliant, again, I was going to raise that, so I'm glad you've ended on that too. I loved this great thought that you have an illness identity for all those years, and then maybe you realise you're actually on the spectrum of normal.
Yeah.
And actually then you need to find your recovery identity. And what an empowering thing that is. And you mentioned as we sat down what's going on, I think, did you say in Sweden?
Yeah, that's right. So, I mean, the concern is that basically in order to recover, you have to believe recovery is possible. And a lot of the kind of discussions we have around neurodevelopmental disorders in particular now make them seem like permanent features of one's life. If you don't believe that one can mature out of something and one does not believe that one can recover, then how does one recover? But I was really relieved. I met somebody from Sweden last week at a festival, and they were telling me that their experience now, and I hope this is true, that in Sweden, young people who were given various medical labels in teen years are now actually going to their doctors and asking to be de-diagnosed. And I hope it's going to be a trend. I'm not advocating for people not getting help, but it's the labeling that concerns me. There's an interesting study I mentioned in the book about people with cardiomyopathy, so just a congenital heart problem. And people who identify very strongly with being people with a cardiomyopathy in this study, they were more likely to end up going to the hospital, more hospital appointments, more medical needs than even people who had worse heart disease. So identifying very strongly with a medical diagnosis can really focus you on your symptoms and amplify them.
Amazing. Thank you so much. Right. Questions, everybody. There's so many topics here. Should we start at the front here and then move backwards? Thank you.
You said that you felt that the overdiagnosis problem arises from the intention to do good. Do you not find anything sinister about this, in that people are having to conform to the idea of the perfect human, and also there's a lot of money to be made out of things? Thank you.
Yeah, I mean, so very often when I speak, people will raise the question of big pharma and mobile phones and social media companies and things, and I don't want to dismiss that as a factor. But I think that in a way it's us letting, I always think, you know what medical diagnosis does is it kind of lets us off the hook a little bit sometimes. So now I understand myself better, and I kind of I can be kind to myself because I understand myself better through this diagnosis. But I often think when we look outward to these sinister actors as a cause for the overdiagnosis crisis, we are letting ourselves off the hook there as well a little bit, because you know what, there's no medication for autism, and that's like rising at massively huge rates. These things do matter. There will be people capitalize on diagnosis. There are clinics, doctors, scientists, pharmaceutical companies who all make huge amounts of money out of overdiagnosis. But I don't believe that it arose from that. I believe that it rose out of a trend that began in the 80s, 90s, where we decided to do a lot more screening for illness on the assumption that finding things earlier was always the right thing to do. And we started doing a lot of this diagnosis creep of picking out things. But I think that does come from the perfectionism that you mentioned. You know, that is where society lets itself off the hook a bit. What we are is trying to let itself off the hook with overdiagnosis. We have a kind of perfectionist society that doesn't expect to age, that doesn't expect to fail, that thinks that we tell our young people that if they want something badly enough and they work hard enough, they will get it. You know, it's sad, but that isn't actually how it happens. You can only get things that are within your kind of frame of your abilities. But we're creating the impression that anything is possible, that graceful aging is always possible, and therefore we kind of set people up to medicalize themselves. So I wouldn't call it sinister, but I completely agree with your point about perfectionism, and I totally agree that people are making money out of this, but I don't believe the making money was the first thing. I believe that it was a societal medical trend that fed into societal need that people then made money out of.
Agree. I think we've got a gentleman at the back.
Thank you, and thank you for an excellent presentation. I'm halfway through your book and very enjoying it. I'm just wondering, do you see social prescribing as a way out of this? And how would you feel as a doctor if the people who are tying everything together in the way you so eloquently described are not doctors?
Yeah, I would love to see more social prescribing as being more available to doctors. I mean, I see patients who have, for example, epilepsy, who, you know, most people with epilepsy, just in case anyone in the room with epilepsy, most people with epilepsy, 70% seizures just disappear on the appropriate treatment and you're 100% well, but there's a small group of people with epilepsy whose seizures just don't get better no matter what you do, and they're the kind of group that I see, the people whose disease is the hardest to treat. And very often I feel, you know what those people don't want me to do is just keep throwing more drugs at them. Often it's all I have. What they actually want is something that will make, you know, that will make their life fuller, and often that's social change, be it a volunteer job that they can go to that will allow them have purpose in their lives that I can't find them because I don't know how to find it, or just an interest outside of their homes which they have difficulty accessing because of their disability. So I would love to, you know, it's quite difficult when you're in a hospital to affect what's happening in the lives of people outside that hospital is unbelievably difficult, but I think for lots of people it would have a much bigger impact on their lives than another drug. So I would love to see us move more in that direction.
Fantastic. Any other questions? At the front here, thank you. We'll go to you and then you. Thank you. So there's a lady, yes, you first. So about the fourth pew back. I just want to make sure everyone can hear you. I'm sure you can project very well.
Thank you. I actually haven't read your book, but I found it a very interesting discussion you've had. I just wanted to understand, in your kind of peer of doctors, how have they responded to your book? Is it kind of deemed controversial, or is it kind of widely accepted that this is a thing that's happening? It would be interesting to understand what your experience has been.
Yeah, I would say that I get a huge amount of support from a lot of doctors. I think this, you know, nothing I'm saying here today did I invent or come up with myself. You know, this concept of medical overdiagnosis has been a concern within medicine for decades. There's a whole bunch of medical movements that surround it. In the UK, it's called Too Much Medicine. In Canada and other places in the world, it's called Choosing Wisely. These are medical movements to try and encourage doctors to stop over-medicalizing. So I think that these concerns are widely held within the medical communities. Of course, if you are a doctor who is working within a system in which you are the person who is dependent on, you know, patient with disorder A or B, in order to fill your clinic and to research upon that person and to find, you know, I haven't spoken to anyone, for example, about the early diagnosis of dementia, but I would imagine if you're a scientist who's trying to find the cure for dementia and you need all of those early diagnosed patients in which to trial your treatments, you won't be madly in love with what I'm saying. But I think because, and I understand the position, you know, for scientific advances, we need to do certain things. We need to try things. We need to do tests on people. And it's just really there is another side to that. And if you're going to put yourself forward. So I would say for the most part, this is something that most doctors are very worried about. However, if your own personal practice depends on making more diagnosis, then things I'm saying are challenging.
I think there was a question just in front, was there? Maybe it's already been answered. Thank you.
Well, it's very close to the last question. So adding on a bit, I mean, is there anything done formally, top down in the structure and the training, rather than doctors being concerned about it?
Yeah, I mean, it's a long time since I trained. I do have students, but it's a long time since I trained. I would say that it's only recently, no. Do I think there's anything specifically in the training? No, I don't think there is, actually. I think that, you know, there are movements, and you see loads of medical papers in the British Medical Journal and other high-profile journals that address these issues, and there are supplements in journals that address this issue. But I'm not sure that I know of that it's not a very prominent part of medical training at the moment. And one thing I really notice is, because I come from a generation of doctors that was just on the cusp of that sort of, you know, I was in medical school in my first couple of years of junior doctoring. I was in that kind of very low-tech bit of medicine, where it was all super clinical and there was only so many tests you could do. And then I was very quickly introduced into the high-tech world, whereas all the junior doctors or resident doctors I'm now working with have only known a high-tech world. And I can see that they're much keener on that high-tech. I think some of the doctors of my generation will be slightly horrified of how many tests are done that aren't necessary. But with a bunch of doctors who grow up in a high-tech world, it can be harder to get that message across. But no, I'm not sure it's become a formal part of the discussion in medical school yet. I'm not sure, but I could be wrong.
One last question, if anybody's got one last question down here at the front. Thank you. We've got 2 minutes, so thank you for allowing one more.
Thank you. I'm really interested in what you said about people identifying with their diagnosis. And I wondered if you had any thoughts, and you had a question about social prescribing. I wondered if you had any thoughts about the investment in mental health support and psychological therapies, and whether those areas can have any impact where people have an identity with their diagnosis, whatever it is.
Yeah, I mean, what I would like to see is, instead of, so what happens very often now is in schools is, and it's not the fault of schools, it's what's available, etc., and what is that we accommodate rather than intervening. And that's really what your question, I think, points to, in a sense. You know, what's happening now, for example, if you're a child with mental health problem, you're diagnosed, and again, we're talking mild end spectrum here. You know, someone with severe autism couldn't even be in school unless they had all sorts of provisions in place. So that's not the group I'm talking about. I'm talking about the mild end of the spectrum. What we do at the moment is we accommodate, and that means saying, well, okay, you're in school, this is difficult for you, so I will create this environment to make it easier for you, and I will give you longer time in your exams to make it easier for you because you have this disability. And I think what we should move towards is intervention, which, whether that be, it depends on the individual needs, but where you are helping people to cope with their difficulties in a messy world, rather than creating the expectation that the world will continue to accommodate to you as you get older, which it most certainly won't. So I would like to, whether it be psychological therapies or whether it be just finding a system in which we teach people to live in a messy world, I think that's the direction we should be heading in.
What a wonderful place to end. It is a messy world. Thank you so much, Suzanne O'Sullivan. What an incredible session.
Thanks a lot. Thanks, Susanna.